All right, let's move on with case number 1. Ayo. It was brought to us by Molly Curtis, who's a Pediatric Emergency Medicine Fellow from Riley Hospital for Children in Indianapolis, Indiana. She presented this case with Tyler Arnold. It's a previously healthy and fully vaccinated 7-month-old male with a rapidly progressive rash. It initially appeared the night prior to presentation as skin-colored round spots. Kid's been afebrile. He did have rhinorrhea and cough that began 2 days prior to the arrival of his skin findings. By this morning, the rash had progressed to multiple annular, non-blanching, violaceous patches and plaques over his face, ears, buttocks, and extremities. The only place that was spared was the trunk. In his left ear, that was the worst. It was notably swollen and proptotic. He did have a course of amoxicillin a month ago, and on exam he's fussy but consolable, afebrile, he looked well hydrated. His breathing, circulation, and mental status are normal, as is his, middle ear and throat examination. Let's take a look at the rash. Here is his face and a close-up of his left cheek and the external ear. Now let's take a look at a posterior view of his ear from 2 angles and a little bit of his left arm. Notice how swollen and proptotic it is. Now here is a foot and a leg. And finally, his left arm. The team got some labs, as one does, and the CRP was 3.7, the ESR was 11, the D-dimer was 3,485, he had a normal CBC, coags, electrolytes, and fibrinogen. His viral PCR was positive for enterovirus and rhinovirus. So, what is the diagnosis? Is it A, bruises from non-accidental trauma, B, idiopathic thrombocytopenic purpura, ITP, C, acute hemorrhagic edema of infancy, D, multisystem inflammatory syndrome in children, MISC, or E, meningococcemia? You've got 30 seconds to guess the correct answer on your own. And the correct answer is C, acute hemorrhagic edema of infancy. Though the rash was dramatic, the kid was stable and just admitted to the hospital medicine service for observation. Plastic surgery declined to intervene on the auricular findings. They didn't think it was a drainable auricular hematoma. Dermatology did a mic drop and made the diagnosis based on the history, morphology, and that positive viral PCR alone, and didn't feel that a biopsy was necessary. So acute hemorrhagic edema of infancy is a benign, self-limited leukocytoclastic small vessel vasculitis that follows a viral URI. It's most common in children 4 months to 2 years of age. If they did a biopsy, it would yield an IgA vasculitis that's similar to Henoch-Schönlein purpura, but without the systemic involvement. The rash itself is characterized by rapid onset of small erythematous macules and papules that progress to annular targetoid purpuric plaques or even broad ecchymoses. Patients are generally well appearing, and though there's no specific lab findings, you can see elevated inflammatory markers. Spontaneous recovery is expected in 1 to 3 weeks. Why wasn't it non-accidental trauma? Well, ear bruises are always worrisome for NAT, but the clinical history suggested otherwise. ITP, the lesions were a bit more dramatic than your typical ITP, and the onset was a little too close in time to the URI. ITP usually follows a URI by a week and a half to 2 weeks. MISC and meningococcemia, the kid was afebrile and well appearing.